Well, good morning, good midday, good afternoon. My name is Shu Sanitani, and I am delighted to be your host for the Let's Talk SADS live Canadian edition. And we are now in our second episode, having just launched this series. And as you will tell throughout this half hour or 40 minutes we're going to spend together, I am new at this and finding my way. So I'll appreciate your patience and good humor. Um, as you can see, I've got a whole new fancy studio set up here that is courtesy of Evan Kruger, who makes a wicked virtual background for us and is our tech support. Big thanks to Pam Husband, the executive director of SADS Canada, and who got this going. As well, our SADS US are close partners in this, and we shamelessly have been inspired by Mike Ackerman and Alice Lara and Aaron to have a bit of a Canadian content to the SADS conversation. And since I never know exactly who's out there, I'll introduce some general principles of what we're doing here. So SADS, of course, is the Sudden Arrhythmia Deaths Foundation, and the name is something that people often comment on, but it works. It's recognizable. It's an international organization, and we are a support group and an advocacy group really around the prevention and support following sudden cardiac arrest, mostly from inherited heart disorders, inherited and hidden heart disease. And so this webcast is really about sharing our learning and learning together collaboratively. And as I said, we're just getting started. So the first few episodes have been really designed around us finding our way and introducing some of the Canadians who are important. So of course we opened last month with Pam Husband to give us a bit of a story on her journey with SADS Canada, and really was one of the pioneers of the whole SADS concept. Today we have a very special guest. There's no name in Canada that comes to mind above Andrew Krahn's name when you think of who's been active in the sudden arrhythmic deaths sphere in Canada for probably 3 decades now. I don't want to age him, maybe a little bit longer. We're going to learn about that. So Dr. Andrew Krahn is the founder of the Hearts in Rhythm organization, and that was really the culmination of years of work in the inherited heart rhythm space. He is the current president of the Heart Rhythm Society, and this is an uncommon occurrence to have a Canadian president of the Heart Rhythm Society. The earliest one that I could find was Dr. Ann Gillis, who was about 10 or more years ago. And so it's not a common thing to have a Canadian president. He's the outgoing president of the Canadian Cardiovascular Society. And as I mentioned, he's been just a real driver of genetic and inherited heart conditions in Canada. I'll just remind the audience, put your comments in the chat. We're not really in a position to offer medical opinions or to get angry at the misdiagnoses or if onlys. But if you do have questions that we can help with, please type them in. The prompter rolls pretty quickly, so try and keep them relatively focused. And with that said, let us please welcome Dr. Andrew Krahn into the studio this morning.
Good morning, Shu. Nice to see you.
Andrew, it's so good to have you here, and thank you. I know you're, as always, juggling a very busy schedule. Andrew changed some travel plans before traveling halfway across the world to be here with us. So thank you. Now, I forgot to set up my Canadian trivia, so you're going to have to sit through this. And people will remember from last month that I want to introduce some Canadian fun facts. And I invite the guests to do so. So in view of it being a very important piece of information, Andrew, I wonder if do you recognize this woman? I won't hold it against you if you don't.
No, she could be many people's great-great-grandmother.
Yeah. So this is Jenny Kidd Trout, and she was the first female physician licensed to practice medicine in Canada. And this was in 1875. Now, this was in Ontario that she got her license. But interestingly, just a couple of more facts about her. So she actually suffered a nervous disorder and was treated with electrotherapy. So, 150 years ago, treatments that are still used today in some extreme cases. Now, she was put through quite a few hurdles before a woman would be allowed to study medicine and had to do a significant qualifying process. And then when she was qualified, there was no medical school in Canada that would take a female. That didn't happen until about 10 years later. Queens had a women's medical school. So she went away for medical school and then came back to Canada and practiced. And she retired from medical practice at the ripe age of 41. And one of her research interests was opium poppy, which of course is morphine. So our fun Canadian fact today is Jenny Kidd Trout. Last month it was George Mines, and I think some of you will remember that we're going to have a contest at the end of the year. So hang on to these trivia bits. Now, I
do have one little tiny fun fact, if you
please
have time. So you just prompted me to remember that, in fact, in the Heart Rhythm Society used to be called the North American Society of Pacing and Electrophysiology, and I think in its third or fourth year, Bernie Goldman, who was a cardiac surgeon from Sunnybrook, was actually the president. So there is a third person who's been in this leadership role. But at the time, it literally was 30 people meeting in a room. And so it's, and it's now 7,500 members. So it's come a long ways. But Bernie Goldman's to be acknowledged as one of the founders and leaders.
And yeah, thank you. And George Van Hare does have some Canadian claims. I think his grandparents were Canadian. So he used to tease me that he was actually the first Canadian PACES president. So Andrew, on this historical journey, I have to show one more picture here. Let me see if I can do this properly. Evan always gets nervous when I start trying to share. So hopefully, so this was in better times for the Seahawks. Russell Wilson was quarterback, and Andrew and I had a wonderful trip. They played the Giants, and it was absolutely a blast to be there. So, it's not all just work with the two of us. Tell us a bit about how you got into, what you would describe. You're a family doctor. I love that quote. So tell us a bit about your beginnings.
Well, so I think that the good story starts. I was a fellow. This was in 1994. So there's your 3 decades. And I was in clinic with one of the consultants, and he said to me, "Go down to the stress lab and supervise treadmills on these 2 boys." And I said, "Oh, what's that about?" Because of course we usually do stress tests on older folks. And they said, "Well, they have something called long QT." And I said, "Okay, it sounds interesting. I don't know much about it, but enough to know what it is. What am I looking for?" And he said, "Well, arrhythmia," which is a very general term. And so the reason this is important is because these 2 boys, their names were Derek and Trevor, their grandmother actually died 3 months after giving birth to their mother. And their mother, in fact, had a cardiac arrest while exercising. And so then I'm down there looking at these 2 10 and 12-year-old young strapping boys. and they're undergoing treadmill testing, and I'm looking at their EKGs thinking that they're very abnormal, and realizing that I need to learn a lot more about this, that I'm not sure what the treadmill test would show. How do we then interpret that as being something that makes a diagnosis, or do we change how we treat them, or what should we do about this? And this was long before we knew the genetics of long QT. And so, in fact, if you come to my office today here in Vancouver, you can still see a laminated EKG from Derek, because this was what triggered my interest in long QT, is where this all started. And so, from a history perspective, then I said, well, what's the cause of this? How common is it? How do we treat it? How do we know when people are adequately protected? How do I make sure what happened to their grandmother doesn't happen to their mother or to them? Because, of course, I met Mom there. She was there with her 2 boys. And so, as many people will know, this sort of triggered the idea that studying these uncommon conditions required, you had to be thoughtful, you had to understand things. I was always fascinated by EKGs. But the other thing was that when things are rare, you either learn a lot from one person, or you try to work with other people so that you get a better collective experience to be smarter about it. So that triggered my whole interest in trying to identify all the people who, this was in London, Ontario, all the people who had long QT who were in this group. And then whether that was enough to sort of understand it, I took a big interest in treadmill testing as a way to diagnose long QT and so on. So, and we have learned so much along the way, but then once you do that, then of course, then as somebody who has a different inherited problem then comes your way, and then Bob's your uncle, right?
Yeah, no, it's and London, and I thought you might give a shout out to George Klein, of course, who's one of your amazing mentors, and interestingly, he ended up having to take over when you moved to Vancouver and get back into the clinic that started it all. Now, HERO is obviously a much better acronym, and we'll acknowledge Paul Dorian as the only person that pronounces it HIRO. But now that's a much better acronym. But take us through a little, because we're about at the 20-year anniversary of the first Casper paper, and we briefly had a cigar acronym. So how did we get to HERO?
Yeah, it's a really good question. So, so out of that, the first action to do was, first of all, was I submitted a grant to the Heart and Stroke Foundation to try to study long QT on a more systematic basis. Again, this is all before genetic testing. And although the first genes were being described at the time, this was very fundamental research and not something we were applying to patients. And that process of after 2 tries getting grant support then meant the ability to say, okay, I've got the resources now to collaborate with other people. So then reached out and said, well, to do this, what I should do is identify some friends, some other people who do my job in other Ontario centers. So I got 3 other centers to then say, let's combine our experience first with long QT, but then broadening from there. And maybe about 6 or 7 years later, I looked after a young woman who'd had a cardiac arrest while swimming. And and her name was Angela. She was a lovely lady. She had 2 beautiful little daughters. And I had a fellow who had done his PhD in long QT related stuff from Australia. And I'd said, well, why did this woman have a cardiac arrest? Because she didn't look like long QT. And we looked at all her test results and so on, and said, well, what could we make something happen? Could we provoke an abnormality? And this is one of the things, if you meet heart rhythm doctors, you'll see one of our themes is, because most of the time our rhythms are normal. And the question is, what brings about something happening in that instant? And so the question is, can you reproduce that? Can you stir things up to try to make something happen? So he said, well, what if we give some adrenaline? Would that maybe make something happen? And in fact, we did. And when that happened, then we came to a diagnosis with her, because we triggered some abnormalities that said, okay, now we have a path to go. And now we have a way, for instance, not only to recognize and treat her, but also how to look for the same problem in her family. because this is the kind of thing that can be inherited. And so the interesting thing about this was then to say, well, this is a very uncommon situation, this unexplained cardiac arrest. Could it have a genetic explanation? So now we need to go beyond the 4 places that we're working on. And then that 4 became 8. And then that 8 became 11. So it became a network. So around 2010 or so, no, a little before that, probably around 2006, we then created this network called the Canadian Genetic Heart Rhythm Research Group. And so that research group was 11 or 12 sites across Canada. These were, for the most part, adult sites, with the exception of the great Dr. Sanatani. And this was physicians interested in research and trying to identify these inherited heart rhythm conditions and inherited heart muscle conditions too, or cardiomyopathies. And so what happened is, so for years, I was able to get funding to support this, and we were very focused on clinical manifestations of these conditions. But the interesting part about this was we were making progress in this in a way, but then around 2015, I literally woke up in one morning and said, I know what's missing. And what's missing is something that I'd said 10 years before. Is my goal was to say Canadians should live near an expert. They should have access to experts. And for that to work, we have to involve the people who provide the care and the patients and their families. So the aha moment was literally to say, we need to rethink this. So this can't just be a bunch of smart doctors sitting in a room debating what the EKG shows. It actually needs to be a group of people that includes the providers and the patients and the families. And the reason we don't traditionally do this is because it's really messy, right? People, they think differently. They have different priorities. We have to spend time kind of understanding and educating each other about our perspective and so on. And, but I said, we just have to do this. And so some people will remember in 2016, we had our first meeting where we essentially brought the whole community together. So we had, I think, about 60 people came to Vancouver. And this involved patients who said, just a minute, sir, with all due respect, you don't know what it's like to have a cardiac arrest and then not know why. Or you don't know what it's like when, you know, your sister lost her son. And now you have uncertainty about how safe, not you are, how safe your kid is. And so that then led to this concept, and we just renamed it because it was we called it Hearts in Rhythm Organization, because it couldn't be about doctors and it couldn't use technical language. And so the nice thing that's happened there is it's an intentionally sort of messy, holistic approach to this. So right now, for example, we've now had 6 annual meetings. Usually about 100 people come together in different places across Canada. But our CFO, if you like, our business lead, is a parent. And the administrative lead, the chair of our executive, is a genetic counselor. So it's not about doctors. It's actually about better care. And I'm really excited about that. I can talk about this all day.
Yeah, no, I think I've had the privilege of going to all the meetings, except I think there was a COVID-y sort of one that I think I was away for, but they're amazing. They're amazing sessions, and the physicians. Certainly I'm always humbled by the lived experience and what the families bring to it. And just last week, I think last week it was, Mike Ackerman had the Glaucom Flecken couple. He, of course, of great Twitter fame, and well, both of them of Twitter fame and influences. And her message was so clear about the psychological impact of administering CPR to your spouse. And that was really a theme that came up also in our last HERO meeting, wasn't it? The psychological support for these conditions is just not there. And so, HERO and SADS, I think, have great opportunities to advocate for the patients. How can HERO and SADS support each other? HERO has a very clear annual meeting and a research arm and stuff. What can SADS learn from Hero and vice versa?
Well, so I see them as complementary. I mean, it's a little oversimplified, but what I would say is, SADS is for patients and families, by patients and families. And so it's a different angle of education, opportunity, innovation, support, and so on, than the intentional sort of involvement of patients and families in something that's also the care providers and the researchers in terms of the discovery side of things. And so, we've, if you like, involved each other in activities and try to communicate best that we can so that patients have all of the opportunities they can to sort of meet their needs. And I think they're complementary. I think the other thing is, you're going to laugh at me, but as you know, with all those titles that I've had lots of sort of leadership and administrative roles. And I have something called the rule of sevens, which is, it's not true until you say it 7 times. You have to write it, you have to say it, you have to digitize it, you have to do it all over again. And then the 7th time you do whatever you think is going to be most likely to be effective. And then it's actually out there and true. And so I don't think it's possible for patients to have too much access, different angles, perspectives, supports, and ways to think about things. And so that's why I think having two groups, if you like, who approach the same thing from a slightly different angle is complementary.
Yeah, no, and I should tell everyone out there, Andrew is a wonderful mentor to me and many others, and so I'm writing down this rule of sevens, as we're talking. So always some pearls to take away. Now, probably a weird question, but do you have a favorite condition amongst the inherited heart rhythm and cardiomyopathies, like where you're like, oh, I could spend my whole time doing just this one? I mean, I know you got your roots in long QT syndrome, and there's no offense to all of the patients who don't have your favorite condition, but do you have one that you resonate?
Yeah. Well, so if I go back to the 80s, actually, one of the reasons I got into this field and everything was feeling like I had no clue. EKG seemed so hard and so non-intuitive and so difficult to learn, but so important. And I remember, for instance, I went to Ottawa for an elective at one point, and just having a chance to learn from Dr. Martin Green, who is just an absolute EKG wizard. And then an EKG then just became something that was always a fascination, which is how it changes when you have a treadmill test, like young Derek and Trevor, for example. So I have to say long QT got my fascination in terms of the ability to sort of recognize this. And the other interesting part of it was that it then became a very useful tool in the gene era to also kind of understand the use of genetic testing and what the findings were and so on. So I have to say long QT. Maybe it's like so many things, when it comes out at the beginning, it really imprints upon you more so than things as they sort of evolve later, or maybe just because I'm losing it as I get older. But yeah, I will say long QT.
Yeah.
So,
well, and it's become so much more nuanced than when it was just an ECG. And yeah, now I'm just going to share my screen here a moment, if I can. And I'm just going to pull this up here. Where is this now? All right. So congratulations on this. So hopefully all of you are seeing this announcement from just a few weeks ago, where Hero celebrated the milestone with the 1,000th participant in a Canadian ARVC registry. And just a little sidebar. Please note the illustration, the heart with the puzzle, and then the little bit of the DNA on the puzzle piece. So that looks like very familiar artwork. So let's talk about both things. Let's talk about the ARVC registry and what a success that is. Congratulations. I think that was one of the more challenging research initiatives to get going.
Yeah, so I think patients and families may be a little less aware of what some of the things that happen in the background, but for some of this to happen in terms of bringing things together, you need financial support for the research side of things, and then with that, you need to find support for also the sort of organizational part of things. So, this started off originally with this unexplained cardiac arrest, or CASPR is the acronym for this. And then the next thing in line was actually a national lung QT registry, where we have actually more than 1,000. And then after that was ARVC. And those are about every 2 years. This is writing grants in a competitive environment to the Canadian Institute of Health Research, or CIHR, and had the good fortune of getting successful support for that. And then 2 years after that, what happened, and it actually started in 2017, that got funded in 2019, was packing HERO as something to our government as an initiative that integrated all of the inherited heart conditions, and also then pitched this idea of this kind of holistic, integrated care application, knowledge translation part of things into doing the research. So I'll take an example, like you discover a test, like we did the adrenaline test 20 something years ago. And very rapidly, within 6 months, that discovery then turns into a network conversation about using the test. So you don't have to wait several years till people figure out that how it's helpful, or gets into guidelines, or somebody goes to an education thing. We do that right within the network to say, hey, we found this, let's do this. So ARVC is an example where we said, this is a condition that for us is common. This is a condition that scares us in the sense that bad things happen to people when they're not well cared for or not well recognized. And sometimes bad things are the first thing that happens. And so we need to be ahead of this and understand it better. And so, it's a little bit of a tangent, but what I'm really inspired with is that HERO now also has a sort of next generation of people who are smarter and better looking than us, Shu. And they're across the country. They're in the first 10 years of their careers. And one of them is Julia Cadron-Tourigny in Montreal, who is an ARVC superstar. She's the Wonder Woman of ARVC because her work has been in identifying risk and using that to inform what the best treatments are for ARVC. And it's just a privilege to have somebody like that, inside our tent. So she's now utilizing our ARVC registry as a mechanism to help with risk prediction. And now we're working on things around blood tests and gene therapies and this kind of thing. So it's very cool. And the inspiring thing is we're now talking to patients about things in a much more informed way.
Yeah, and your grant writing has fueled so many of these advances, and I think what people don't necessarily understand is that you have a full-time job, and then by the way, you're funding a lot of the research that's happening in the Canadian genetic heart rhythm space, and and definitely we're going to have some of this next generation of people coming on, and we'll see if they accept our invite for guests. Julia, I noticed, was doing an international webinar on just that, ARVC risk stratification, and wonderful to see her thriving in this. And she started as well with the Canadian. I always feel that the Canadian genetic heart rhythm landscape really, the strength is in its community, because we're a small country, population wise especially, but we've been very productive and involved in the conversation, and so much of that is through your leadership. Now, you mentioned the next generation coming, but we still have lots for you to take on. Tell us a couple of the things that you're excited about for the next couple of years. I know you had talked about supporting the next generation. Tell us a bit about where things are going that you're excited about.
Well, so I'll tell two stories. So one is I got an email from somebody who's a relatively new pediatrician in Southern Alberta, who said, essentially, I'm interested in this field. I'm seeing patients, these families, these young family members, and I know about Hero, and I'm interested in wondering whether you have things that can help us develop a more structured clinic where we can identify families, and also how we can create stronger connections with the adult people who work in our field. And my heart just swelled at the idea, as I said, oh yes, for sure. You know, our website has a whole toolkit for clinics. We've mentored and helped to sort of birth some clinics in this area. And he said, because my goal is to create basically a patient and family safety system for Southern Alberta. I'm like, oh, wow, you know, this is why we do this, right? Is because you know, it has so much more impact when it becomes a network of people that are all rowing in the same direction. So on the one hand, what I'm looking forward to is that, you know, the original goal of giving people access to experts actually means effective prevention, so that we have less tragedies and we get ahead of this, and people and patients have better lives. So, and I think Hero is one of those things that's sort of gaining momentum in the sense of people being able to find us, knowing that there's expertise, people like SADS recognizing that we have like a network of clinics and people can find a clinic, just like you can find an expert through SADS and so on. So that's on the one hand. So on the other hand, what I would say is the really nice thing is when I started, this was sort of about EKGs and saying, oh yes, you have long QT or you don't have long QT. But now, in fact, it's all the way from, you know, genes and cells and hearts and EKGs to patients and coping and prevention measures and so on. But that sort of integrated journey is now leading to the question, rather than can we recognize and mitigate, can we actually fix this? And so, you know, we know that, and people will have heard the term CRISPR, but we know that this idea of gene editing, or the ability to kind of fix genes when you inherit an abnormal problem, is the kind of thing that is now quite feasible to try to change our DNA. And the journey started, you know, realistically, probably about 15 years ago with the whole idea of, can we do it? Can we do it safely? Will it work? How do we do it? Who should it be applied to? Those kind of things. But that's now translating into something where, you know, for instance, this past May, there was a presentation where somebody said, we took some ARVC patients and we fixed their DNA. And this is very much at the kind of proof of concept level, but enough of work's been happening across CPVT and long QT and ARVC and some of those more common conditions, to the prospect of saying, you know, there is a very real possibility that our generation, for instance, will be the last one where our DNA isn't edited to our advantage. And so the conversation with patients actually for me has changed quite a bit to say, hang in there, good things are really coming. And so, for instance, we now have some research agreements with companies that are literally have a single target, like, for instance, the most common gene for ARVC is called plakophilin-2 or PKP2. And their target is to fix that. And wow, wouldn't that be thrilling? You know, I hope I can work long enough to see that say, you know, come to us and we'll vaccinate you from ARVC. Cool.
Yeah, no, it's incredible. And sorry, and you've reminded me, I didn't follow through on part 2 of showing your ARVC slide. Was that a Cassandra Krahn original, that heart with the DNA puzzle?
Actually, no, it wasn't.
Oh my goodness.
Yeah, no, but so all I'll say is that, you know, I have 5 people who work as the coordinating center for Hero in Vancouver, and they are an inspiring young lot. Let's put it that way. And many of them will probably be watching, but they're just a lot of fun to be around.
All right. Your alarms are going off. Anyway, but Cassie Krahn is an incredible artist, and I know she did some of the early works when we were looking around for logos and things. So a shout out to her.
She did the picture behind me too. So
yeah, fantastic. Yeah, no, and just this past week there was some buzz about hypertrophic cardiomyopathy and correcting genetic genetic misprints and changing the course of diseases. So yeah, I think, you know, the next 5 years, I think, will be very exciting. We've also talked a little bit about the concept of, you know, how come you can't just find all the patients? Like, you know, what if everyone just had an ECG when they were born? Like, why should anyone suffer these tragic events that, you know, that have brought us together?
Well, put it this way, that's a really big, complicated question. So I'll throw something out to sort of provoke thought. And so one of that is, you know, when this all started, research was the place where genes were discovered, and then the ability to access genetic testing, and then companies came up that offered it, and so on. And so now, I think in Canada, it's fair to say if somebody thinks you have a genetic condition, there's typically access to genetic testing. But the cost and the access to it is just getting better over time. And so by now, for instance, there's talk about things like, you know, you could get most of the relevant genetic information for $200 to $500. And so then you say, well, why not get all of that genetic information at birth, right? We do heel pricks and keep blood samples and stuff. And so the answer is, our DNA has a lot of natural variability in it. That's why we're not all clones. That's a good thing. And some of that variability doesn't matter biologically, doesn't cause trouble, but a small amount of it does. And that's when you get long QT or ARVC or HCM or those kind of conditions. And so on the one hand, the technical capability of generating genetic information is quite easy. But in fact, genetic information ends up being much more complicated, and knowing what it means is really challenging. So if you and I did our DNA, for instance, we'd find probably 5 or 6 things that would potentially appear to be disease-causing or lethal that don't seem to be causing trouble. So how do you manage all of that? And so, you know, I'll take an example, like, let's just say my daughter pops over for dinner and she introduces somebody who's a friend, and they leave a little fingerprint or saliva on their cup. What if I sort of, wonder what their DNA shows? So you wouldn't want me doing that. I obviously wouldn't or shouldn't. But our capability of doing that outstrips our ability to know what to do about it, whether it's ethical, whether it's right, whether it's actionable, and how we manage it. So simple DNA isn't the solution to knowing what's going to happen. You know, Peter Schwartz did a wonderful study in 42,000 babies many years ago to look for long QT, and found long QT mostly in babies, many of whom probably, quite frankly, may never have been detected, and many of whom didn't have known long QT in their family. So the problem is not that we shouldn't, it's actually how we could, or how to make it useful and balance being alarmed with the prevention agenda. So we've got a lot of work to do on how to do that at the sort of public policy and implementation, as far as I'm concerned, so that we don't, you know, mostly set off alarms and actually have relatively little effect on protection.
Yeah, and I note that Tim has added a very important concept to our chat, saying, you know, family history really is the key. And so pay attention to who your parents are. Andrew, we're at time here. I've really enjoyed, you and I could probably talk about this stuff all day. And I always learn so much from your historical journey. Any last comments? I know you're rushing off to the airport. Any last comments for us?
Well, it's been really nice to be here, and I like the kind of informal dialogue part of things. I think the one thing I will say for sure is one of the things I believe is anything can be improved. Something that's working well can be even better. And so, you know, through social media channels or emails, I'm still a little bit of an old fart. I still use email a lot. These are ways to push suggestions our way, to say, have you thought about this? Is there a way to do this better? Why haven't we answered this question? Because we want to hear, that's the point of HERO, is to try to say, we want to hear from patients and families on what the agenda is and how we can collectively make it better. So I'm kind of inspired by the opportunity, but it was really good to sit and talk about this, and hope the community finds it beneficial.
Yeah, no, thank you so much. And I think the SADS and the Hero it's a natural partnership, and lovely to be able to do it with a good friend and collaborator. So thank you so much, and safe journey.
Thank you.
So always great to chat with Andrew. He's done so much of this. I didn't even talk about his over 400 publications, and I did pick up on the fact that he had to rewrite one of his grants. Usually his grants are so well written that he gets awarded the grant. Anyways, we won't tease him about that. A couple of comments coming in, and I think thank you for joining. You'll remember in January, with February being Heart Month, I talked about getting out and refreshing your CPR. So there's still a week left. 25% of February is still there for those of you who haven't gotten around to refreshing your CPR. And remember, surround yourself by people who will give you CPR should you need it. And of course, we're always still looking for your comments and your ideas. We are excited. Next month, we have none other than Michael Ackerman scheduled to join us and talk about another giant in the field. And Mike needs no introduction to this space, but we're excited to have him. And then after that, we're gonna start diving into some more of the sciencey things, and we're gonna have a genetic counselor teach us all a little bit about DNA and how why genetics has become a household word without us necessarily fully understanding what it means. Again, SADS Canada and all the SADS organizations internationally are dependent on the generosity of our supporters to do things, and to promote awareness, to keep a website going, to organize events. And so feel free to click on our link and make a contribution in honor of Heart Month. And I have been delighted to be here today with Dr. Andrew Krahn, and I look forward to seeing you in 4 weeks' time at the same time and same place. So